presenting on oral hygiene and health inequities, why nurses should care, and how we can help. We nurses have a lot on our plates already, so why should we prioritize dental hygiene and dental health? Let the dentists worry about that, right? Wrong. Our mouths matter. A smile, or lack thereof, is often the first impression we make. Short-term problems with oral health affect socialization and can be the difference in getting hired for a job or beginning a new relationship. Right or wrong, we often make judgments about a person's character based on the appearance of their teeth. But long-term, studies are showing us that oral health is strongly linked with other issues of morbidity and mortality, such as heart disease. It is estimated that 50% of heart attacks may be associated with oral bacterial infections. Also, digestion begins in the mouth with the extremely important process of chewing. If foods are avoided due to dental problems, or even if the process of chewing is simply limited by missing or maloccluded teeth, this alteration in the first stage of digestion can mean that macronutrients may not get broken down into micronutrients, leading to malnutrition, which affects overall health, the ability to fight disease, including the oral bacteria, which can spread from the mouth to the heart and ultimately infect and or stress a number of other body systems. According to the World Health Organization and the National Academy of Sciences Communities and Action Pathways to Health Equity text, health equities are systemic differences in the inequities are systemic differences in the opportunities groups have to achieve optimal health, leading to unfair and avoidable differences in health outcomes. A few of the many differences which may make lack of access to healthcare and healthy living options include minority, race and ethnicity, gender, underemployment and or low socioeconomic status, disability, immigration status, geography, rural or limited transportation. In 2017, the Global Burden of Disease study estimated that 3.5 billion people worldwide are affected by oral diseases, from dental caries, cavities, to mouth cancers, to noma, a severe gangrenous disease of the mouth and face which kills 90% of the 140,000 new cases each year. Those who survive are permanently disfigured or disabled. One population that experiences health inequities is the working poor. Though many of the other populations at risk of health inequities often end up falling into the category of low socioeconomic status, race and all the isms listed on the previous slide are strongly correlated with low socioeconomic status. This association between oral health and overall health exists from early childhood to older age. Oral diseases and diseases which we now know may originate with oral infections disproportionately affect the socioeconomically disadvantaged. Poor overall oral health is associated with adverse outcomes for mothers and young children. Oral health. From preterm labor to low birth weight, to early childhood caries, oral health of mothers affects the unborn child she carries, in addition to the young children in her care. From 2010 to 2020, a limited yet controlled study of nurse-family partnership nurses in Miami who provided education in the homes of mothers and young children was completed. Some of these nurses received special education on oral health practices and passed this education on to the mothers. Health outcomes for the mothers and children involved were improved. Many low-income individuals live in rural areas without oral health care. These people may lack the transportation and or the time that it takes away from work and family responsibilities to get to out-of-town providers. Additionally, the fact that many people only go to a dentist when they have a severe problem means that many associate dentists with pain, fear, and negative things such as tooth extractions. Establishing healthcare hubs in order to accomplish multiple health-related visits in a one-day trip is one step in the right direction for patients near and far. For the last 5 years, the state of Massachusetts and Harvard Health Equity professional Shannon Wells, MSW, has found that establishing care centers which integrate oral health, mental, and behavioral health as well as primary care together, not only in the same physical facility, but as an organization and for individual staff. The mission at the core of their practice is to not only coordinate care for access and convenience of clients, but to maintain down to earth, innovative, collaborative relationships between all providers, which has proven beneficial to clients' health and quality of life. For instance, mental health and primary care providers might work with dental staff to appropriately medicate patients with lengthy or complicated medication and health histories prior to painful or stressful dental procedures. Given that both time and transportation can be a barrier to health access for many low-income individuals, in the last decade, the use of fully outfitted dental vans has been utilized in areas like Central Texas and the boroughs of New York. Though these programs have primarily been focused on and successful in triaging and treating existing dental problems, given emerging research in the area of oral health, some of the resources are beginning to be shifted towards education and prevention. St. David's dental vans primarily visit Title I schools, but also parking lots of a handful of medical clinics. What began with one van now has grown to 9 fully staffed vans working together with school nurses and clinic providers, primarily nurse practitioners, to improve the health of clients. Despite numerous attempts at legislation to stop SNAP, aka food stamps benefits, from covering sugary sweetened beverages and candies, the legislation has not been passed. Nevada University did a study in which SNAP beneficiaries were targeted on Facebook with an ad warning against the perilous health effects of drinking sugar-sweetened beverages. Up to 30% of SNAP beneficiaries polled reported seeing the ad and changing their behavior based on the information. Perhaps such ads could be shown in waiting or exam rooms for government offices, health and dental clinics without using our patients' personal information to get onto their personal devices. Nurses are trusted individuals in our society. Patients listen to the information we share, and they are more likely to trust other professionals they associate with us. We have power and an important voice from our patients' homes to schools to the state and or U.S. House, where we can and should advocate to stop funding sugar-related disease and start integrating oral health into healthcare and education. The mouth is an essential part of the human body and experience. Let's use ours to advocate. References. More references.